Hey, welcome to the pharmacology update for Nursing 666 at the University of Southern Maine. Anybody else can watch it too, I guess, but I'll put it up on my YouTube channel if anybody else is interested. But it's mostly for the NP students. It's trying to update you with what's gone on since we did pharmacology a couple of years ago. We've got some really interesting drugs that are on the cusp, and some others that are on the horizon. So sit back and take it in. Alrighty, so there's a couple of other things just to mention that are related to pharmacology. These things are not pharmacology, but there's two lab tests that you'll be hearing a lot about: the Gallery test and the CancerGuard test. Recent data is not all that impressive on them, but they are being pushed to the public, and they do screen for multiple cancers. The challenge, of course, is that when you get these positive tests, those people then call their PCP and want you to do other screening and other testing, and insurance can be pretty sticky with just those indications. So stay tuned. Who knows what's going to happen with these, but they're definitely out there. Cytochrome P450, there's definitely still the testing. I still occasionally do the GeneSight testing. Insurance coverage is still not great. There was an article in the Nurse Practitioner Journal last year, actually a year and a half, 2 years ago now, that talked about them, and I think they're getting more popular, but they are really pretty much exclusively for people that are having problems with certain drugs. Psych uses them a lot because it's very hard to tailor drugs, and it's hard to predict what drugs people will respond to. Because to be honest with you, psych is still a fair amount of trial and error. So they do it a lot more than we do, so you'll sometimes see it used, but there is a little more interest in it as time goes on. Xolair has been around for a long time. You're probably familiar with it. It has a MAB suffix, so it is a monoclonal antibody. We've used it a long time for people with asthma, people with those kinds of things. But it does have a new approval in 2024 for people that have type 1 allergic food reactions. So if somebody has nut reactions or those kinds of things, and it's really hard to keep them from being exposed, they can start on Xolair, and it will prevent or dramatically decrease those. It can also be used, of course, for eosinophilic asthma, urticaria, chronic rhinosinusitis. Haven't seen it used for eosinophilic esophagitis, but one would assume it probably could be. Neffy is being heavily advertised. Neffy is just a nasal inhaled version of epinephrine. It does seem that the data is pretty comparable to the use of an EpiPen, so I think you're going to see more and more as time goes on. But it is something that is out there. It's a little bit more expensive than the EpiPens, but the EpiPens are so expensive that, especially with discounts and things, people can usually get their costs down to a pretty comparable level. And especially in younger children, it's probably going to be something that is pretty appealing. So, Kisunla and Leqembi are drugs for Alzheimer's disease. They have been IV infusion drugs. Fairly modest benefit, but again, with Alzheimer's, any benefit you can get is worth considering. Leqembi now has a subcutaneous version that the patient can give themselves or family can give them. Both of them can cause amyloid-related imaging abnormalities, and also will have some edema or some hemorrhagic elements to them. So it is something that if these patients are going on to these drugs, usually neurology or whoever's prescribing them will do ApoE testing, and if it is abnormal, it does increase the risk of these. But like so many of the drugs we're going to talk about today, these are often not drugs that you're going to be prescribing, but drugs that your patients are on from one or another specialist, and that you do need to factor into your care. I do think Kisunla and Leqembi are still specialist drugs, but who knows, as time goes on, and especially with nursing home patients that have a hard time getting specialist consults, it may be something that we use more. Vabysmo is really the big kahuna as far as wet AMD. The others are being used. They don't hit quite as many of the receptors. Vabysmo blocks both VEGF and ANG2. Eylea and most of the others just do a single receptor. So Vabysmo is the one that is kind of preferred at this point. But I think as the time goes on, the ophthalmologists will get that much more sophisticated and be able to maybe use some of the cheaper drugs for lesser versions. Right now, there's really three major indications for these drugs: wet macular degeneration and diabetic macular edema, and people that have a retinal vein occlusion, both a branch retinal vein occlusion or a central retinal vein occlusion. They do seem to provide substantial benefit. There is a somewhat higher risk of arterial thrombotic events, such as stroke or MI, but one needs to keep an eye out for these things and know that the risk is higher. But again, many times other folks are going to be prescribing these. They are very expensive, but most insurances will cover them if someone has at least halfway decent insurance. Winrevair is another sept drug, so it is a blocker, a kinase blocker. It does work for pulmonary artery hypertension. Most medications for pulmonary hypertension were vasodilators that were more specific to the lungs. Things like sildenafil, which is why every time you prescribe sildenafil, they'll ask for a PA. If it is for this, insurance will cover it. If it's not for pulmonary artery hypertension, most insurances will not cover it. But Winrevair is an activin signal inhibitor. It binds to that protein. Does seem to have substantial benefits as far as better 6-minute walks. Does have some changes on the blood count, but these are usually relatively mild, but do need to be monitored. It's an expensive drug, and again, usually will be managed by either pulmonology or sometimes cardiology managing pulmonary arterial hypertension. Zevtera is a 5th generation cephalosporin, does have better Pseudomonas coverage, has good MRSA coverage, even in people that have resistant MRSA infections. It is used for community-acquired bacterial pneumonia, as well as endocarditis. Again, going to be used rarely because it's expensive and rare and hard to get, but it is a advance as far as options for antibiotics. Bevquec, which is a Vovec drug. Again, the drug companies have added these random 4 letters at the end to decrease the probability of look-alike drugs. But this is a gene therapy. Gene therapies are probably going to be the major elements of things as far as advances over the next 10 to 15 years. The past 10 to 15 years have been the monoclonal antibodies. The gene therapies are going to change the world. This particular one doesn't really edit genes. It actually adds a gene, and it will add a gene that decreases the need for factor VIII infusions. It increases the probability of a patient being able to make their own, I'm sorry, not factor VIII, factor IX. Because it's for hemophilia B, not hemophilia A, so it's factor IX. There are some others. Hemfasi actually works for both hemophilia A and hemophilia B, but it's a non-gene therapy. It's a monoclonal antibody. So we didn't have a lot of hemophiliacs for quite a long time because we basically killed them all off because of HIV. Unfortunately, the place where most people got their factor VIII was from donations, and many times those donations came from prisoners, and unfortunately the prisoners had a higher probability of being HIV positive. So in the 1980s and early 90s, we really decrease the population of hemophiliacs in the country. It does seem to be increasing again. I've got a couple on my panel now, but it is still pretty rare. So it is a niche drug at this point. Roctavian is also a hemophilia A drug. They're actually withdrawing it from the market, but just to let you know that they're doing more and more of these virally mediated gene therapies. So basically, they create a gene, they put it in a virus, the virus goes into the cells and adds this gene to the cells. So basically, a lot of these are virally mediated gene therapies. And the next step, of course, will be medications that are used to alter a patient's genes. Almost all of those are CRISPR-Cas9 variants. Very few that are on the market at this point, but I think within the next 5 to 10 years, you're going to see dozens of them. Casgevy is one of those. Casgevy is approved. It's basically curative for sickle cell anemia. It basically goes into the patient's cells and edits the BCL11A gene, which is very critical in vaso-occlusive processes for patients with sickle cell anemia, obviously the vast majority of whom are African American. And so this is a major scientific advance. We had done some bone marrow transplants for people with sickle cell anemia, and there were a few cured from that. But this is going to be a widespread therapy and may actually even wipe out or dramatically decrease the number of people with sickle cell anemia. Alpha-1 antitrypsin should be very soon. There's a lot of genetic disorders that are basically just single gene substitutions. Sickle cell and alpha-1 are examples of that, and there's probably another 10 or 12. But they're more rare diseases. But the more common diseases like cystic fibrosis and those kinds of things definitely can be treated with CRISPR-Cas9 technology. But they do require a little bit more development before they'll be ready for prime time. There's concern because, of course, CRISPR-Cas9 can alter anybody's genes to create any kind of a outcome. So the concern is that there's going to be people that do it to edit embryos so that you get blue-eyed children or stronger children or whatever. But it is something that is greatly thought about. I mentioned in class Jennifer Doudna. Jennifer is a Nobel Prize winner in 2020 for chemistry. I think she's at Berkeley at this point, and she is a pioneer with CRISPR-Cas9. The guy that wrote the biography of Steve Jobs, Walter, escaping me right now, but it's a great book. It's called Codebreaker. And she also has another book called A Crack in Creation, which is actually prior to her winning the Nobel Prize, but it has a lot of explanations of the science that's involved. So CRISPR-Cas9 is the wave of the future. Trivio is a new advance as well. It's an endothelin receptor antagonist for blood pressure. They're already using it in Europe. It is available here in the United States. Right now it's on what they call REMS restrictions, which is reduction of mitigation of problems. So they're just watching it more closely. So we'll see. It is a pretty substantial alteration from a lot of the previous drugs that were either sympathetic nervous system based or were renin-angiotensin system based. This actually gets into the endothelin, right into the actual blood vessels. So there are some medicines that had worked on the blood vessels, but this does seem to be a substantial advance, but time will tell. Romanidine is also a centrally acting alpha agonist. Could be used as blood pressure, already being used that way in Europe. As we know, a lot of these alpha-1 agonists also do have psychiatric and other benefits. Haven't really seen anything specifically for rilmenidine, but um, it's a you know, one that's on the horizon, and stay tuned. Zerlasiran is a medicine that has been developed by Silence Therapeutics. It's basically gone through stage 3 trials with very positive effects. Unfortunately, Silence Therapeutics doesn't have enough money to develop it and market it. They're looking for a partner, and at the same time, Novartis, Amgen, and Lilly all have equivalent medicines that affect LPA, LP little a. So LP little a is a subtype of bad cholesterol. It's really the one that's most problematic. And to this point, we don't have any medicines that will lower specifically LP little a. One of these four medicines, I think, will hit the market aggressively within the next year or two, and will be an option for that. But again, time will tell. Resdifra is a medicine that's being used for MASH, metabolic associated steatohepatitis. It's interesting because it works on a certain type of a thyroid receptor that regulates fat metabolism, and it decreases the deposition of that fat in the liver, and also has some pretty positive effects on the blood lipids. So again, this is another one that we're going to have to keep an eye on. It is approved for use in MASH now. Ozempic is also approved for use in MASH, and does also seem to have good effects as far as decreasing the deposition of fat in the liver. The GLP-1s hold a lot of promise, and as I think I've mentioned a bunch of times before, I think Ozempic and Zepbound slash Mounjaro are different than the others because they have more of an effect on GIP, but you know, definitely that's known from Mounjaro. For me, that's just my theory for Ozempic of why it works better than a lot of the others. Zelsuvmi is a medicine that is now available for molluscum. Right now, molluscum is a condition usually that teens and younger kids get. They get these umbilicated little lesions. They last anywhere from 3 months to a year. They'll go away on their own. Eventually, your body figures it out and gets rid of them. But some folks are distressed by the appearance and don't want to wait a year for them to go away. And so up to now, we've had to use either cryo or cantharidin, which is basically a wart treatment. This one is more specific for molluscum. You mix 2 tubes of gel together and then apply it, and most of the lesions are gone within 12 weeks, some sooner. Basically releases nitric oxide, which works almost like a cryo effect to get rid of the lesions. So it's another option now that's available. Again, I haven't seen it used at all, even by dermatology, but it's out there. Sofdra is a medicine that's used for excessive sweating. Usually people have had to fail Drysol, which is the most common one that we use for excessive sweating. This medicine can be very expensive. I've had people that really worried about their jobs because they sweat so much if they did presentations. You can put those people on beta blockers. You can send them to dermatology, and dermatology will sometimes use Botox for them. But it would be good if there was another option for treatment, and this seems to be one that may have some promise. Sulfiam is an interesting medicine. It's basically a carbonic anhydrase inhibitor. Carbonic anhydrase inhibitors are used as diuretics, but also decrease the production of aqueous humor in the anterior chamber. This particular one, interestingly, also seems to decrease certain types of seizures. Rolandic seizures are most common as nighttime seizures. Many times people that have Rolandic seizures don't even really know they have them, but they can have problems with bedwetting. They can have problems with nighttime issues, and it's worth thinking about if you've got somebody that has bedwetting prolonged. Um, the weird thing is that some of the people that they put on this have decreased their sleep apnea pretty substantially, and so they're thinking that this may have a role for sleep apnea. There's another drug called AD109 that's also in trials for sleep apnea treatment, which is eroxybutynin slash atomoxetine. Atomoxetine you may recognize is an ADHD medicine as well, a non-stimulant ADHD medicine. Zepbound is also approved for sleep apnea, but just because something is approved doesn't mean insurance is going to want to pay for it. So unfortunately, I have a lot of people come in and say to me, can I get the Zepbound? I have sleep apnea. And I'll prescribe it, and the insurance still won't pay for it just because. So it is a sulfa drug, Solthium is, but it really doesn't have any antibiotic effect, as you might expect. Lasix is also a sulfa drug, interestingly enough, or furosemide, whatever you want to call it. Ensifentrine is just another phosphodiesterase inhibitor. Lots of options for COPD. Not a lot of other major side effects, but just to throw out that you may see this one used. Atruby you've seen advertised heavily on the TV. Morgan Freeman is advertising it. It basically treats amyloidosis. Amyloidosis is a deposition of certain types of fats and proteins in the heart and other parts of the body as well. You can have a systemic amyloidosis, and basically it decreases the strength and flexibility of those muscles. There's other medicines that are also amyloid medicines. Vindamax is another one. They also think SGLT2s may also have a role in ATTR-CM, but this is going to be, again, a cardiologist drug predominantly, but you need to be aware of it. Interstitial lung disease, we're seeing more and more of it. Mostly we're seeing it, I think, because we now have a treatment for it. Up until now, we just said they had fibrotic lungs, and there's nothing we can do about it. But if patients have fibrotic lungs, there's a couple of options that we can use, Esbriet or Ofev. We don't really understand the mechanism of action of these medicines, but they do seem to decrease the fibrosis of the lungs. They may actually increase clots, however. So again, it's kind of a stay tuned. You'll sometimes see pulmonology put patients on these drugs, so you do need to be aware of them. The CGRP medicines have been out for a little while, but I think it's worth mentioning. Nurtec, which is Japan's drug, is now approved for every other day for prevention. So if you have somebody who is having a lot of migraines, usually we'll try the every 3-month drugs such as Aimovig or Ajovy. The Vyepti is the Vyepti is every 3 months. The Aimovig and the Ajovy are every month, as is the Emgality. So it is one of those things that you can prevent it, but all of those are injectable. The Nurtec is a new advance because it's the only oral one that can be used for prevention. All of the other Japan's drugs are rescue medicines. There is a nasal version, Zavspret. There is a new Ditin drug that's on the horizon as well, Lasmoditin. It seems to cause a little more sedation. I haven't seen it used yet, but just so you know, it's out there. Apixaban, the big thing I think is the Cobra trial, which showed 50% less bleeding than rivaroxaban. Most people have used the Apixaban just because they did feel like it had less bleeding, but the Cobra trial did support that. The rivaroxaban is just once a day, so that is an advantage. The Apixaban is twice a day. We are using it more in the 2.5 milligram dose for maintenance after DVT sometimes, and in cancer patients. They're using it more in pediatrics because they do have studies now that support it. The generic of apixaban should be out within the next couple of months, so I think that'll really change a lot of things and a lot of options. GLP-1s, as we said, they have lots of benefits, mostly for diabetes and weight loss, but we also see benefit in arteriosclerotic cardiovascular disease. It's one of the few things that does help with HFpEF, heart failure with preserved ejection fraction, also known as diastolic heart failure. Really, diuretics and the GLPs are kind of the mainstays at this point. The SGLT2s probably do have some benefit as well. The GLP-1s definitely have some benefit as far as chronic kidney disease. They have benefit as far as metabolic associated steatohepatitis. As noted previously, we do have the benefit of especially the Mounjaro, the tirzepatide, also known as Zepbound when we use it for weight. And again, unfortunately, just because they're approved for these things doesn't mean that they're going to get covered by insurance. There's some interest in benefits of the GLP-1s for patients with substance abuse, mental health. Studies are ongoing there, but there's no real data that I've seen that says anything conclusive, but there are some anecdotal reports that suggest that some people really do get better. There is a 3G medicine. We talked about GLP-1. We talked about GIP, which is kind of a precursor of GLP-1, and we know that Mounjaro also affects GIP levels. There's another drug coming out from Lilly, who also make tirzepatide, that also affects glucagon. So that'll be coming out within the next year or two, and it'll be interesting to see if that changes the cost of any of the other drugs or how that impacts the market. Arexvy, which is an RSV vaccine, previously had been 60 and up. Now it's approved for 50 and up. I tend to reserve it for people. I think that RSV is really just a really bad cold for most people. And so there are some people that a really bad cold would kill them. Patients with bad COPD, patients that are relatively fragile, and I really do push the RSV for those people. Other people, I make sure they know it's available and they're aware of it, but I am not as aggressive in recommending it. Cobenfy is a medicine that you're seeing advertised on television a lot. It's an antipsychotic, but it says it's technically not an antipsychotic, even though it decreases psychosis symptoms. I think that they're splitting hairs there, but they do want people to know that it's not the same as most of the other antipsychotics. It really doesn't work on the dopamine track. It works on the muscarinic system, which is a tract of the parasympathetic nervous system. Usually they have minimal weight gain, which unfortunately with a lot of the other antipsychotics, they have substantial weight gain. Right now, the Cobenfy is twice a day, and that is a problem with any psych med because it's hard to get people to take things once a day, much less twice a day. And they're working on a long-acting injection, so hopefully that'll be out soon. They have aggressive discount cards, so most people with any type of insurance can get it, but they also have a fairly high sticker price if one doesn't have a discount. Narcan is a drug that we all know and love, has great advantages. There is a new medicine called nalmefene, which is out, which is basically the same thing. It's a narcotic blocker. The biggest difference is Narcan has a half-life of about 30 to 90 minutes. Opvee lasts as much as 11 hours. And so if you've got somebody that has a long-acting medicine, or that they have a lot in their system and it's going to take them a while to metabolize it, a lot of people are moving towards using the Opvee. They're all expensive, but usually you can access it without too much cost. And they also think maybe the nalmefene is better for fentanyl, but again, this is a stay tuned kind of thing as well. And just a reminder that most of us are not going to prescribe a lot of these new drugs. We just really want to be aware of them so that when the specialists prescribe them, we know what they're doing, and we can factor them into the patient's overall primary care. So hopefully you learned something in this half hour, and let me know if there's other things that we need to talk about, and feel free to post anything in the comments of the YouTube posting if you have comments.